Hi everybody, my name is Dan and I'm a mental health pharmacist, and today I'm going to be presenting on opioid use disorder. There are four major objectives to this presentation. By the end of this presentation, I will hope that you will be able to differentiate between the types of opioid-related disorders, identify the treatments for the three major types of opioid-related disorders, contrast between opioid antagonists, partial opioid agonists, and opioid agonists, and identify the proper routes of administration and combinations of medications. This presentation will be separated into four major sections. First, I'll start with some background by defining what an opioid is and going through some historical context in regards to opioids and the opioid epidemic. Then I will go through the guidelines and go through what the guidelines say and how to treat these various opioid-related disorders. Third, I will go a little more in detail into the medications, and finally, I will address stigma. So without further ado, let's go into some background information. First, I wanted to start with what is an opioid. An opioid is any natural, synthetic, or semi-synthetic chemical that positively affects the mu-opioid receptor and other opioid receptors. This will work on nerve cells in the brain and body and reduce pain signals. Under the big umbrella of opioids, there are naturally occurring products, which are classified as opiates, semi-synthetic, and full synthetic. But whether it's an opiate, semi-synthetic, or full synthetic, it all falls under opioid. Opioids originally come from the poppy plant. So if you take the pod of the plant and slice little slices into it, a waxy substance will come out, and this is opium. And opium is 10% morphine by weight, which is a type of opioid. So poppy plants have been cultivated for thousands of years, so using opioids or opioid-related products is not a new phenomenon. I did want to present on some historical components. So though opioids were used for thousands of years, the first component of the opioid epidemic seems to be related to the Civil War. So for example, during this time, Union soldiers were issued over 10 million opium pills. Additionally, the hypodermic syringe was invented during this time, so people could inject the medication right into their bloodstream and get a lot of that euphoria, a lot of those highs, and those effects from opioids. So abuse began to become a problem. So much so that the government intervened. So with the Harrison Narcotic Control Act, one of the components of this was opioids are no longer available over the counter and have to be prescribed by a doctor or a prescriber. So then for a long time, opioids were used. They had some benefits, they had some problems, but during the 80s to 90s, there were a few articles that came out that were positive towards opioids, saying that we were under-treating pain, more people need to be on opioids at higher doses. And one of these articles was found to be a letter to the editor and not really backed up by much medical evidence, but it essentially said that out of 11,000 people, only 4 became addicted to opioids. So this began a push towards using more opioids. In fact, the American Pain Society in 1995 really had this push for pain to be regarded as the 5th vital sign. So check temperature, heart rate, pulse, pain, all sorts of things. But pain should be addressed, but not necessarily frequently or always with opioids. So after these positive evidence came out and the pain societies were being more active, the pharmaceutical companies were being more active, prescriptions of opioids began to increase by quite a bit. So much so that in the mid-2000s, it was already becoming quite an issue. People were developing use disorders, people were overdosing and dying, and the government in 2006 made it that primary care providers could see more patients and prescribe more medications to treat opioid use disorders. 2007, a big-name pharmaceutical company pleaded guilty for misleading doctors and misrepresenting some of their products. And for this initial case, they had to pay over $600 million. Finally, in 2017, the opioid epidemic was declared, and this was declared a national emergency. One of the reasons why this is so concerning is so many people are dying. So if you look at the orange line, this is prescription opioid deaths. And right around the late 90s, this began to elevate quite a bit. But this is still a much smaller line than the blue line on the graph that's synthetic opioids, things like fentanyl and things like that. These are extremely fatal when used improperly, and many, many people are dying from this. So if you look at the picture on the right of the penny, the little amount of white dust to the side of it is the amount of fentanyl that it requires to be fatal in an overdose. So these synthetic opioids can be really, really dangerous. So next I wanted to go into the DSM. So this is the manual used in psychiatry to standardize the diagnosing of mental illnesses. Within the DSM-5, there are a few types of opioid-related disorders. First, I'll start with opioid intoxication. So this is the medical term for an opioid overdose. Next, I'll go into opioid withdrawal. So this is when someone takes opioids for a long period of time, suddenly stops, and they have symptoms of withdrawal. And finally, I'll go into opioid use disorder. So this is essentially the medical term for opioid addiction, long-term problematic use of opioids. So I wanted to go a little more in detail into the DSM, and I'll start with opioid intoxication. So the diagnosing of opioid intoxication is pretty straightforward and pretty much exactly what you might expect. So it's recent use of an opioid followed by symptoms of having too much opioids. So pinpoint eyes, drowsiness or coma, slurred speech, impairment in attention and memory. So relatively straightforward. Next is opioid withdrawal, and this is also relatively straightforward. So it's the cessation of opioid use that has been heavy and long-term, followed by symptoms of withdrawal, things like dysphoric mood, nausea and vomiting, muscle aches, diarrhea, insomnia, and so on. Finally is the DSM-5 criteria for opioid use disorder. So this is, again, the medical term for opioid addiction, and this is a problematic pattern of opioid use leading to clinically significant impairment in some of the following symptoms. There's 11 in total, but I just highlighted some of them. So this would be things like opioids are taken in larger amounts or over a longer period of time than it was intended, unsuccessful efforts to cut down, cravings, tolerance, withdrawal, and another component is failure to fulfill major role obligations. So is the person not going to work because they want to get opioids, or not going to school, or not taking care of their kids? So there's real functional impairment in true opioid use disorder. Next is the etiology and pathophysiology. So this is multifaceted and complicated, like most things in mental health seem to be. So there are biological differences in people's brains who have opioid use disorder. They have lower dopamine release, and they seek to get that dopamine from external sources. One of those can be opioids. So their brain patterns and brain pathways can be different. Next is genetic risks. So there are certain genes that put people more at risk for developing an opioid use disorder. So when you put those two factors, the differing in the brain, differing in the genes, in combination with stress, trauma, abuse, sexual abuse, then that can really cause those genes to be activated and cause someone to take an opioid once to change their brain pathways and want to continue to use and use and use. Finally, with the introduction, I wanted to comment on racial disparities in treating opioid use disorder. So for follow-up, Black patients are half as likely to obtain follow-up appointments for opioid use disorder care after discharge from the emergency room. Opioid overdose death rates are still very high, but have leveled off in most patient populations, but still continue to rise in Black populations. Next is access to care. So counties with more Black and Hispanic communities have more methadone clinics. Counties with more white communities have more buprenorphine clinics or use. So this is just something to be aware of when you're seeing and treating your patients. So with that being said, let's go into the treatment. So interestingly, the treatment for opioid-related disorders go back to that opioid receptor. So sometimes we use a full agonist, which this is how opioids work to treat opioid-related disorders. So fentanyl, heroin, Percocet, hydrocodone, all of these are full mu opioid agonists. Sometimes we use that as a treatment, like methadone, which I'll talk about later. Other times we use a partial agonist, so still working on this mu opioid receptor. It activates the receptor a little bit, but not as much as the full-on opioids. And sometimes we want to block this receptor completely and use an antagonist like naloxone or naltrexone. So again, the treatments for opioid-related disorders often run right through that same opioid receptor. So I have a few patients to walk through. So first we have patient A. Patient A presents to the emergency room with the following symptoms: very slow or irregular breathing, not waking up or responding to touch, pinpoint pupils, their skin's turning blue, slow heart rate. So what type of opioid-related disorder is this patient experiencing? Is this opioid intoxication, opioid withdrawal, or opioid use disorder? So feel free to pause and think about it, but this patient is experiencing opioid intoxication or an opioid overdose. The guidelines are quite simple and straightforward here. So your first line intervention for opioid intoxication is naloxone. Naloxone is a mu opioid antagonist. It blocks that receptor completely. Not only does it block the receptor, but it kicks off the opioids. So if someone takes too much opioids and they're having these symptoms of an opioid overdose, naloxone binds to those same receptors, kicks any opioid off, and the person can survive that opioid overdose. But why are opioids fatal in overdose? What are they doing? So taking too much opioids suppresses breathing. It causes respiratory depression. So if you watch videos of first responders going to the scene where someone is overdosing on opioids, they're often making like hiccuping sounds or snoring sounds or gasping for air, and they're kind of not really conscious either. So people stop breathing when they take too much opioids, and that's how they die. So patient B has been on a medicine floor for 3 days for an infection, so they've been in the hospital for 3 days. He took his last dose of heroin shortly before admission. He becomes anxious, has insomnia, is in pain, is sweating, has diarrhea. What type of opioid-related disorder is this patient experiencing? So feel free to pause and think about it. But this patient is in opioid withdrawal. So opioids cause pain relief, they cause sedation, they cause euphoria, they cause constipation. So opioid withdrawal causes the opposite of this. It causes pain, it causes insomnia, it causes dysphoria, causes diarrhea, and causes other symptoms. The timeline for opioid withdrawal depends on which opioid is taken. If it's something with a really quick onset and offset like heroin, they might go through the withdrawal relatively quickly. If it's an opioid with a really long-acting duration, they might not have these withdrawal symptoms until a week or even longer after stopping the opioids. So many hospitals use a scale to assess how severe the opioid withdrawal is. This is called the Clinical Opioid Withdrawal Scale, or shortened to be called COWS. So this is an interesting scale. It has both subjective and objective measures. So for example, subjectively you'll ask the patient about anxiety, but objectively you'll look at their pupil size and so on. The scores can be seen here: mild, moderate to severe. So your treatments for opioid withdrawal based on the guidelines can be seen here. First line, you're typically going to use buprenorphine or methadone. One really important piece to know here is that you do not start buprenorphine or methadone until the patient is already having symptoms of withdrawal. So using that COWS score, maybe they have a 5 or a 6 or a 7. This may be dependent on the hospital or the clinic where you work. And there's a very good reason why you do that. So if someone's on heroin, a full opioid agonist, and you give them buprenorphine, which is a partial agonist, you're going to cause their effective opioid levels to go down, and you're going to cause withdrawal in that patient. So you wait until they're already on the come down, already in withdrawal, and then you give buprenorphine to level them off. Methadone is a full opioid agonist. So if someone's high on fentanyl or something like that, and you gave methadone on top of that, you're going to potentially throw that patient into an overdose. So the point here is you wait until the patient's already in withdrawal, starting withdrawal, before you start an opioid-related product for withdrawal. The good thing about these treatments, the buprenorphine and methadone for opioid withdrawal, is you can roll these right into the long-term treatment of opioid use disorder. Some patients don't want to be on opioids anymore, and you can just treat them symptomatically. So common medications here are clonidine or lofexidine and a few other medications. Clonidine was originally developed as a blood pressure medication. It's an alpha-2 receptor agonist. Well, when someone's withdrawing from opioids, they have a surge of norepinephrine that can cause a lot of their symptoms of their withdrawal. And clonidine or lofexidine helps to prevent that surge from happening and prevents a lot of the effects. These are medications in the same class, so choosing between them can come down to a few factors. One is that clonidine has been out for a long time, so you can see the pricing on the picture here, but it's relatively affordable. Whereas lofexidine is a brand name product, is branded at this time, and it's quite expensive. With that being said, a study has shown that it had less side effects than clonidine. So clonidine might be your option to be more cost effective. Lofexidine might be your option if the patient has more resources or better insurance and so on. There's additional treatments you can use as well. So opioid withdrawal will cause diarrhea often. You can use antidiarrheals. It will cause pain, so you can use non-opioid pain medications. It can cause nausea. You can use antiemetics and so on. Now we have patient C. So patient C has a long history of using fentanyl and not being able to save money or keep a job. He wants to be treated so he can maintain his new job. What type of opioid-related disorder is this patient experiencing? Opioid intoxication, withdrawal, or use disorder? So since this is the long-term issues with opioids, this is opioid use disorder. So what does the guidelines say about opioid use disorder? Well, it says that you can use a partial agonist like buprenorphine, a full agonist like methadone, or a blocker like naltrexone. So this can be quite confusing for learners because you can use all different types of opioid receptor products to treat opioid use disorder. So here are the different options. You have the full agonist like methadone, you have the partial agonist like buprenorphine, or the antagonist with naloxone. And they serve somewhat different purposes. So if someone's been on opioids for quite a while, you can replace that with a more controllable opioid or opioid-related product like methadone or buprenorphine. The patient will still have the physiologic need for an opioid, but they will often function better, have jobs, go to school, not have cravings, not have withdrawal. So it's a much more controlled environment with things like methadone and buprenorphine. Next is an antagonist. So say the patient wants to completely be off opioids, you can give them a long-term antagonist like naltrexone, and if they try to use opioids, their receptors are blocked and they won't really work. So now that we have a general understanding of the treatment guidelines, I wanted to go more in depth into the medications themselves. The medications I'll be focusing on are naloxone, naltrexone, buprenorphine products, and methadone. So let's start into naloxone. So naloxone is an opioid antagonist, and this has only one place in therapy, and this is opioid intoxication. So if someone's overdosing on opioids, this is where you use naloxone. And it works by blocking the opioid receptors and also kicking the opioids off of the receptor. So you only use this if someone's overdosing. One of the reasons why, is this is available as nasal sprays, injections, and IVs. And you don't use this oral. Why are none of the naloxone products available orally? So feel free to pause and think about it. The first is that if someone is overdosing on opioids, they're unconscious, you can't really get that type of person to take a pill. Additionally, oral medications take a while to get absorbed. So that person can die in the meantime if they're not breathing and having that respiratory depression and you're waiting for a pill to take effect. Next is that naloxone is obliterated by first-pass metabolism. So this is when you take a medication, before it goes in orally, before it goes into your bloodstream, it goes through the liver. And the liver is able to really break down naloxone. So if you take naloxone sublingually, buccally, or orally as a pill or a tablet, it's not going to have much of an effect. So these are the reasons why you don't use naloxone orally. These are the different products available, and some of the dosing can be seen here. The onset of action takes a couple of minutes. So again, if you watch first responders' chest cams and watch them coming up to naloxone patients, the patient will be hiccuping, gasping for air. They'll give the nasal spray naloxone product and nothing happens. The patient's still gasping for air and unconscious. And then about 3 minutes in, 4 minutes in, the patient will suddenly come to, and they'll be talking, and they'll be in withdrawal, and they'll often be angry, but they'll be breathing, and they'll be alive. So it takes sometimes a couple of minutes to take effect. Next is the duration of action. So if the patient's on a long-acting opioid that you give them and they're overdosing, and you give them naloxone and they come back, their body can actually clear the naloxone while the opioid's still in their system. So someone can go from unconscious overdosing, awake with the naloxone, and then clear the naloxone and go back unconscious due to the opioids. So sometimes you have to continue to give naloxone. Next, one of the side effects I wanted to highlight is precipitated withdrawal, meaning this medication is causing withdrawal. This is only used for opioid intoxication, so this is exactly what you want. You want to cause withdrawal because you want to kick the opioids off the receptor so the patient can breathe again. Other side effects can be seen here as well. So naloxone, remember, is not available orally, and it's an opioid antagonist. But we did want an oral opioid antagonist in our arsenal, so naltrexone was created. So naltrexone is an opioid antagonist, but it is available orally. This is not used for the acute intoxication because remember, that takes too much time to work. But this is available for the long-term use of opioid use disorders, the long-term treatment. This is available as a tablet and a long-acting injectable, but not a nasal spray, not a short-acting injection, not IV, so it takes time to work. So again, you don't use this for opioid overdose, you do use this for opioid use disorders. Here's some interesting information about the long-acting injectable, Vivitrol. So yes, it increased opioid-free days, which is what we would expect, but also, interestingly, it decreased cravings for opioids, which can be quite helpful. Some side effects of naltrexone are worth bringing up. One is that it decreases appetite. So there's a branded product called Contrave that's naltrexone and bupropion in combination, and this is used as a weight loss product. So naltrexone can decrease appetite. It can also cause hepatocellular injury, so you want to check a patient's liver function tests. Contraindications here are patients who are receiving opioids. So if someone has chronic pain and they're on opioids, you don't want to give them an antagonist or the opioids won't do anything anymore. So now going away from the antagonist at the opioid receptors, I wanted to go into the partial agonist, like buprenorphine. Buprenorphine is still considered an opioid, even though it's a partial agonist at this receptor. So what does being a partial agonist mean? This means that it affects the mu opioid receptors, but it has a ceiling effect. So if you give someone more and more and more heroin, they're going to get more euphoric, higher, and then eventually go into respiratory depression. If you give someone more and more buprenorphine, eventually it stops having more of an effect. So this can be quite helpful because the ceiling effect limits respiratory depression, limits euphoria, limits a lot of the risks that opioids have. This is used for opioid withdrawal. So again, you wait until someone's already in withdrawal, then you can start buprenorphine, and then you can roll this over into a long-term use for opioid use disorder. So like I said, wait till someone's already in withdrawal, because as you can see, heroin and other opioids are full agonists. If you give them buprenorphine while they still have those effects, you're going to cause withdrawal, and your patient's not going to be very happy with you. This is available as a sublingual product and a long-acting injectable product. Side effects can be seen here. And now I wanted to go into buprenorphine and naloxone combination products. So at face value, this combination doesn't make sense. It doesn't make sense to give a partial opioid agonist with an antagonist at the exact same time. But I will hope to explain why they use these in combination. So this is again considered an opioid, and it's a partial agonist with an antagonist. If this is used for opioid withdrawal and opioid use disorder. So the reason that it's okay to use buprenorphine and naloxone together is like we said before. Remember, doesn't work. It's not available when you use it sublingually, buccally, or swallow it as a tablet. It only takes effect if it's a nasal spray or an injection. So the buprenorphine and naloxone combination, when used appropriately, which is sublingually, is effectively just giving buprenorphine, because the naloxone isn't absorbed and it's destroyed by first pass metabolism. The reason they put the naloxone in here is if someone tries to dissolve it in a solvent and inject it, then that naloxone is available. So it is available as an injection. So the naloxone's in there to prevent misuse of the buprenorphine products. There are two major products, Suboxone and Zubsolv. These are both relatively common medications, good medications to know about. Their conversion can be seen here on this slide. So these again are sublingual or buccal products, meaning they're absorbed through the mouth, the oral mucosa. When I used to work at a Suboxone clinic with a lot of these patients, if I ever heard them say they had nausea, they were almost certainly swallowing the medication too soon. So with a sublingual or a buccal, this is absorbed in the mouth, not in the GI tract. So you really want to wait 10 minutes after you put that under your tongue or on your cheek. Don't swallow your spit. Let it absorb as much as you can. Because if you swallow it, it's not going to work, and you're going to get stomach aches or have some issues with it. So it's important to note how to counsel a patient on how to properly take a sublingual or a buccal product. Finally is methadone. So methadone is an opioid. It's a full mu opioid agonist, just like heroin, oxycodone, Percocets, all of them. So why would you use this for opioid withdrawal or opioid use disorder? And the reason comes down to its pharmacokinetics. So heroin has a really quick onset. It causes your dopamine to spike. It causes a rush. People feel euphoria. People get really high. Methadone is a little different. So it has a really nice slow curve to its onset and offset. So it's good for preventing cravings, preventing the patient from going into withdrawal, preventing the patient from feeling pain, and it kind of just is a nice supplement to have it in their system rather than the misuse and the risky use that you can get with other types of opioids. So this certainly still can be abused and misused, but due to its pharmacokinetics, it's a little harder to abuse and misuse. But you still can overdose fatally on methadone. Methadone's only available at clinics for opioid use disorder, whereas for pain, it can be obtained at a regular pharmacy. The side effects can be seen here. And for the final part of the presentation, I wanted to go into stigma. So one of the common arguments or stigmas around patients with opioid use disorders is people will say, is the use of medications like methadone and buprenorphine just replacing one addiction for another? So this isn't true. Buprenorphine and methadone are harm reduction strategies, and you're treating addiction or opioid use disorder, because remember, this is problematic use where the patient isn't working, spending all their money, not fulfilling their major life obligations. Whereas people on methadone, people on Suboxone work. they work full-time jobs, they contribute to society, they take care of their family. So you're getting rid of addiction, but you're maintaining a physiologic need for opioid agonism. So you're still working on that opioid receptor, but it's a much more controlled manner. Next argument is, doesn't treating opioid use disorder cost taxpayers tons of money? So this was one of the arguments when when methadone clinics were opening up or treatment centers were opening up. And the evidence seems to show the opposite. So a 2021 JAMA article, and JAMA is a pretty well-respected medical journal, said that all forms of medications for the treatment of opioid use disorder were associated with cost savings compared to no treatment. And this was $25,000 per $105,000 in savings per patient. So imagine you have a methadone clinic with 100 patients. That's a lot of savings to the healthcare system. And why does this save so much money? So if people are using opioids illicitly and get incarcerated, the average inmate cost per year is $35,000 a year. Someone overdoses on opioids, they go to the ED, that's going to be a couple thousand. The average hospital stay, $30,000. They use dirty needles and get hepatitis. Hepatitis treatment can be $60,000. So by treating somebody with opioid use disorder long term, you're saving the healthcare system lots and lots of money. Next, I wanted to highlight some healthcare professionals' perspectives. So you may expect some stigma from the community, but these patients often face stigma or discrimination from healthcare professionals as well. So it's really important to be aware of this. Found an interesting study about pharmacy technicians where they were doing focus groups. And some of the quotes were quite interesting. So some of the quotes were talking about opioid use disorder patients. They get angry easily. They are very demanding. They're usually the ones who's staying late. We have to call the doctor sometimes and they get very impatient. They're constantly trying to fill their prescriptions early. So grouping together patients into being mean or angry or impatient can be difficult for the patients to manage their disease state. I'm sure these same pharmacists and pharmacy technicians see someone picking up an antibiotic who are stressed and angry and so on. So lumping everyone together isn't always helpful. But there were some positive quotes as well. So some of the pharmacy technicians said, we should not judge a patient because no matter how the patient has the pain or the addiction, it's still a process they have to go through. Another pharmacy technician said it's really important to educate yourself. And another one said, don't form an opinion right off the bat. So it seems like this depends on the person. Some people have more stigmatized thoughts and others have less. Pharmacist perspective as well. So pharmacists aren't clear of the stigma either. A survey of 187 pharmacists indicated that 59%, almost 2/3, have a lack of willingness to interact with opioid use disorder patients. So that's very sad to hear and sad to see. Some of the pharmacists with the higher stigma scores were pharmacists with more experience, greater than 10 years of experience. Those without a personal experience with substance use disorder, meaning a friend or a family member. Those who agreed patients with opioid use disorders require excessive time and effort, and those who agreed that some people lack enough self-discipline to use pain medications. So if you're going into pharmacy, it's really important to pay attention to this. Pay attention to some of your subconscious thoughts and work hard to treat these patients just like any other patient. Nursing's perspective as well. So some nurses said they feel judged a little bit and they don't understand the psych component well enough. Others said that they call security more than most others because they've seen the worst of the worst. But there are some other perspectives as well. Addiction runs in my family, so I've had some outside education. I had my mother who was really sick growing up with cancer on some pain meds. I saw her go through some stuff. And this third quote was quite interesting. I had a patient once who was in so much pain. He had a history of opioid use disorder and we were only giving him Tylenol. And we finally did some scans and he had metastases everywhere. So we were just like, oh snap, we were only giving him Tylenol. For me especially, that kind of put things in perspective. This guy had been clean and we weren't treating him adequately. So this patient was clean from opioids and no one would give him opioid pain medications, even though they didn't know at the time his body was riddled with cancer. Study about doctor perspectives was quite interesting as well. So I wanted to highlight and focus on this first line here. So opioid use disorder is a chronic medical condition just like diabetes, and 77% of doctors agreed with this. Opioid use disorder is a chronic medical condition like diabetes. And you would hope that a high number of doctors would say that, even higher than 77. But, okay, so keep in mind they think that opioid use disorder is similar to diabetes. When they were asked further questions, like if they were willing to have a neighbor with opioid use disorder or have someone marry into the family with opioid use disorder, their numbers went down quite a bit. So if they think opioid use disorder is a medical condition like diabetes, would they have answered that they don't want someone with diabetes moving in as their neighbor or someone with diabetes marrying into their family? So there may be some subconscious thoughts or some subconscious stigma against these patients. Some terms to avoid, some terms to use. So we try to focus on patient-centered language at this point. So you don't want to call someone a diabetic. You want to call them a person with diabetes or a patient with diabetes. You don't want to call them a schizophrenic, a person with schizophrenia. Same with opioid use disorders. You don't want to call them an addict or a user, a person with a substance use disorder, a person with opioid use disorder. You don't want to have terms that have like cleanliness associated with them. So you don't want to say they have a dirty urine. You want to say they tested positive for X or Y. This can affect pharmacists too. So some information I looked at said that 1 in 10 pharmacists will suffer from a substance use disorder at some point during their lifetime. So pharmacists have these same at-risk genes, these same biological brain pathways, and access to a lot of medications that can be quite harmful. So I found a study that looked at pharmacists with substance use disorders. Some of their quotes were interesting. I started abusing prescription opioids when I was a technician/intern. I decided to steal them instead of just buying them. Another one said, every employee has this employee assistance program or line or whatever. I never met anyone who used that had a good outcome. So it's hard to go in there and say, well, I stole about $100,000 worth of your drugs. Can I get help now? So opioid use disorder can affect all sorts of people. Highly educated people, people with less education, people from all different backgrounds. So it's really important to keep this in mind when you're treating patients. So in summary, we started with background information, went into what is an opioid and some history. Then we went into some treatment. So we separated opioid intoxication, opioid withdrawal, and opioid use disorder and talked about how to treat those. And then we went into the specific medications, naloxone, naltrexone, buprenorphine, and methadone. Finally, we ended with some stigma from different healthcare providers and terms we can use to improve this. So I hope this presentation was helpful, and thank you so much for watching.